Welcome to the deep dive. Our job is pretty simple. We wade through complex source material on really urgent topics so you can get up to speed fast on what matters right now. And today, we're diving deep into artificial intelligence in clinical research. Not just its integration, but maybe more importantly, the rigorous oversight needed.
Yeah, our mission today is really to unpack the sources on the global regulatory stuff, the ethics, the organizational challenges. I mean, everything facing clinical research pros. And look, this isn't some future thing, is it?
Not at all.
AI's here, it's powerful, it's available now. So responsible action isn't optional, it's needed today.
Exactly. And that speed, that pace of change is really what defines this moment. We're way past the old AI 1.0 rules-based stuff.
Right.
And even AI 2.0, which was all about pattern recognition, machine learning,
Right.
that feels almost quaint now. We are firmly in AI 3.0, that's generative AI. This is the kind of AI that doesn't just spot patterns, it can generate entirely new text, images, even synthetic data, often without needing specific retraining for that new task.
And when you put that kind of creative, generative power into a really high-stakes area like clinical research, well, the potential for good is huge, but so is the potential for things to go badly wrong. We have to be really careful.
Absolutely. And the sources point out, maybe a bit worryingly, that we're right at the peak of inflated expectations on that Gartner hype cycle, which means, that slide down into the trough of disillusionment is coming. So our goal here is to equip you, the listener, with what you need to navigate that trough and actually get to responsible, productive use. Okay, so let's start unpacking. Where do we begin? The global rules.
Yeah, let's start there. The big trend globally is definitely a risk-based approach. It sounds obvious, maybe, but the core idea is simple. The level of regulation, the amount of oversight, has to scale directly with how much harm an AI system could potentially cause. Harm to health, safety, fundamental rights.
Makes sense. And the big one everyone talks about is the EU AI Act, right? That's the horizontal approach.
That's the one. Horizontal meaning it cuts across different sectors, and it lays out 4 risk categories. It starts, pretty low-key with minimal risk.
Okay.
Think spam filters, maybe using an LLM to draft a first version of an informed consent form, something like that. Low stakes.
Okay, so minimal risk, basically background stuff. What's next?
Then you've got limited risk. The main requirement there is transparency. So if you're interacting with an AI, like a chatbot maybe, it has to be clear that it is an AI. You can't pretend it's a human.
Right, simple disclosure, but then it gets serious.
Then it gets serious. High-risk systems. And for clinical research, this is where it gets really relevant. Think AI used for safety reads, like automatically analyzing ECGs or MRI scans, or maybe AI systems designed to automatically flag protocol deviations, stuff that directly impacts patient safety or trial integrity.
Okay, so safety critical systems are high risk. What does that mean in practice for someone using that AI?
That's the crucial part. The EU AI Act puts legal duties not just on the company that made the AI, but on the user too. The organization actually deploying it. They have a whole list of obligations. Things like conducting a data protection impact assessment before using it, actively monitoring the AI's performance once it's live. It's quite involved.
Wow, okay, so user liability. If I'm running a trial and I use a high-risk AI tool, I have specific legal hoops to jump through, like these assessments and monitoring.
Precise.
Doesn't that kind of put the brakes on things? If it's a huge compliance burden, won't people just avoid using these tools, even if they're beneficial?
That's the inherent tension, isn't it? Balancing innovation with safety. Compliance takes effort, but the regulators argue it's essential to prevent misuse or harm. But to help manage this, they're also looking at vertical or sector-specific rules. And one really interesting development is the creation of good machine learning practices, GMLPs. These were developed by global regulators specifically for AI used in medical devices.
GMLPs. Yeah, I saw that mentioned a lot in the source material. What's the core idea there? Any key principles we should know?
There are 10 guiding principles, but a couple really stand out. One is super important, making sure your training data is truly independent from your test data.
Okay.
Sounds basic, right? But if they overlap what they call data leakage, the AI essentially learns the answers beforehand. It looks great in testing, but fails in the real world. It's like giving a student the exam questions before the test.
Right, it's cheating.
Exactly. The other big one is shifting focus. It's not just about how the AI performs on its own. It's about the performance of the human AI team. The human element remains absolutely critical.
That makes sense. And these vertical laws, they spill over too. You mentioned something about hiring.
Yeah, that was interesting. Like the New York City law on automated employment decision tools, or AEDTs, It requires an independent bias audit for any AI used in hiring or promotion decisions. So if a CRO uses AI to screen resumes for, say, a clinical research associate job, that AI tool has to be audited for bias before they can use it.
Huh. So AI oversight stretches from patient safety right through to HR. It really is everywhere.
It is. Which brings us neatly from external rules, government laws, to internal governance, what organizations do themselves, often called trustworthy AI or responsible AI. You need that internal framework, too.
Right, the organizational side. And looking at the sources, there seems to be a common playbook for these internal programs, doesn't there? 5 core elements keep popping up.
That's right. You typically see bias mitigation, making sure it's fair, explainability or interpretability, understanding why it made a certain decision, then data privacy and security, obviously crucial, robustness, making sure it doesn't break easily. And finally, the one we keep coming back to, human oversight.
Human oversight, the human in the loop. That seems absolutely key, especially when you mention that large language models, LLMs, are just predicting the next word. They're not thinking.
Exactly. They're incredibly sophisticated pattern matchers trained on vast amounts of text, but their goal is statistical likelihood, not factual accuracy or truth.
And that leads directly to this idea of hallucinations, right? Where the AI just confidently makes stuff up.
Precisely.
We had that wild example from the sources about the bears.
Oh, the bears in space, yes. A publicly available LLM just kept insisting that the Russians had sent 49 bears into space. Completely fabricated, obviously.
29.
49. But here's the really unsettling part. People started talking about this online, posting about how the AI was wrong. And the AI then ingested that internet chatter
Oh, no.
and used those posts about its own mistake as evidence to double down on the original lie. It basically trained itself on its own falsehood, reinforcing the error.
That's terrifying. It's like a feedback loop of nonsense. Garbage in, Google out, but the Google is the garbage it created.
It perfectly illustrates the danger. Imagine that in a clinical setting. An AI hallucinates a drug interaction, it gets documented somewhere, fed back into the system. That error could become embedded knowledge.
And that connects directly to bias, too, which isn't amusing at all.
Yeah.
You mentioned that study about healthcare costs.
Yes, a really stark example. An algorithm used historical healthcare spending as a proxy for actual health needs.
Okay.
But because Black patients, due to various systemic issues, historically had lower healthcare utilization and thus lower associated costs for similar conditions, the algorithm interpreted that lower cost as meaning they were healthier.
Wow.
The result: it systematically under-recommended additional care, like enrollment in intensive care management programs, for Black patients compared to white patients with the same underlying health problems, all because the training data reflected historical inequities and no one questioned the proxy being used.
That's a devastating real-world consequence. It underlines why that human oversight, that critical checking, is so vital.
Absolutely. And it also highlights the critical importance of the data itself, the integrity, the structure, especially when you're dealing with protected health information, PHI, under HIPAA in the U.S.
Right, because researchers often want to use existing health records to train AI, don't they? But you can't just dump raw patient files into a model.
Definitely not. You have to de-identify the data first to protect patient privacy. AKA gives you two main ways to do this.
Okay, what are they?
The first is expert determination. Basically, you get a statistician to formally assess the data and certify that the risk of someone being re-identified is very small. It's flexible, but, complex, potentially subjective, and needs real statistical expertise.
Right, relies on an expert's judgment. What's the other way?
The other method is safe harbor. This one is more like a checklist. It's prescriptive, less subjective, but surprisingly strict.
Strict how? I think most people assume de-identification just means removing names and addresses.
Yeah, that's a common misconception. Safe harbor requires removing 18 specific identifiers, and this is where people get tripped up. It's not just names and addresses. You have to remove all elements of dates related to an individual: birth date, admission date, discharge date, except for the year.
All dates except the year. Wow.
All dates except the year. Also, age if the person is over 89. Zip codes have to be handled carefully, often just using the first 3 digits. Biometric identifiers, full face photos, vehicle identifiers. The list is quite detailed.
That sounds way more complicated than just stripping out a name.
It is. And connecting this back, this complexity creates real friction. Research teams often confuse a truly de-identified dataset under safe harbor with what HMAPA calls a limited dataset. A limited data set still contains things like dates and zip codes and ages. You can use it for research, but it requires a formal data use agreement and stricter controls because it's not fully de-identified. People mix these up all the time, leading to delays, compliance issues. It really slows things down if you're not careful.
Okay, so navigating the data rules is a major hurdle, and that hurdle, combined with the power of AI, it naturally leads to anxiety about jobs, right? People wondering, is AI going to replace me?
It's a valid concern, definitely. But I really liked how one of the sources framed it. It said something like, AI will not replace your job as a clinical research professional, but a clinical research professional using AI likely will.
Ah, that puts a different spin on it.
Yeah.
It's about augmentation, not replacement.
Exactly. It's an efficiency tool. The sources used a great analogy. AI is like a chainsaw.
The chainsaw. Huh?
Think about it. A chainsaw dramatically boosts your productivity for cutting wood compared to an axe, right? But you wouldn't just hand a running chainsaw to someone without training. You need to understand how it works, its limitations, the safety gear you need, when not to use it.
Right, you need proper training and safety protocols.
Same with AI. It can make certain tasks much faster, more efficient. But users need to understand its proper use cases, its potential failure modes, the necessary controls like the human oversight we discussed. Upskilling becomes critical.
And transparency from leadership, too, I imagine. If AI frees up, say, 8 hours a week for a research team, what happens to those hours? Is it for higher value work or just more work?
That's key. Clear communication about how efficiency gains will be used is essential to manage that workforce anxiety and encourage adoption.
Okay, one last big area the sources covered. Scholarly work, publications. AI isn't just drafting emails anymore. It's drafting or helping draft actual research papers. That sounds like an ethical minefield.
It absolutely is. It touches the very foundation of scientific integrity and intellectual property.
So what are the main watchouts?
Well, the International Council of Medical Journal Editors, the ICMJE, they've taken a very clear line. AI cannot be listed as an author, period.
Why not?
Because authorship comes with responsibility. An author must be accountable for the accuracy, the integrity, the originality of the work. And AI, being a tool, can't take that responsibility. So human authors must disclose if they used AI significantly in writing or analysis, and crucially, they must validate everything the AI produced. The human is still 100% accountable.
Okay, so AI is a tool, not an author. What about copyright? If I use AI to help write my paper, who owns it?
That's another tricky area. The U.S. Copyright Office stance is generally that content generated primarily by AI, anything more than a de minimis or trivial amount, is not eligible for copyright protection by the human user.
Not copyrightable, so it just goes into the public domain.
Essentially, yes. If the core expression, the creative heavy lifting, was done by the AI, you likely can't claim copyright over it even if you edited it significantly. That has huge implications for protecting novel methodologies or findings described using AI-generated text or figures.
Wow. And this loops back to the hallucination problem, doesn't it? What happens if the AI doesn't just write nonsense text, but fabricates data or images for a publication?
We're already seeing examples of this. The sources cited Italian researchers who deliberately prompted an LLM to create a fake but clinically realistic-looking dataset.
No way!
Yes, they got it to generate data showing one treatment was superior to another, completely fabricated, in just minutes. It looked totally plausible, highlighting a scary new potential for research misconduct.
That's deeply concerning for peer review. How could reviewers even spot that?
It's incredibly difficult. And it's not just data. Remember that retracted paper with the AI-generated rat diagram?
Oh yeah, the one with the anatomically impossible rat.
Exactly. It had nonsensical labels, bizarre anatomy, yet it sailed right through peer review. The authors had even disclosed using AI for the figure, which just proves disclosure alone isn't enough. Reviewers and authors still need to critically evaluate the output.
So the bottom line for researchers using AI in publications is?
Treat the AI's output like a first draft written by someone unreliable. Maybe that fifth grader analogy works. You, the author, are fully responsible. You have to check every single word, every data point, every figure before you put your name on it, because when it gets published, the buck stops with you.
This has been really illuminating. A bit daunting, maybe, but necessary. The core message seems clear. Using AI responsibly in clinical research means blending our existing ethical foundations with new, specific kinds of technological oversight.
That's it exactly. It's not throwing out the old rules, but augmenting them for this new technology.
So, key takeaways for everyone listening. Remember those EU AI Act risk levels: minimal, limited, high, unacceptable. Remember the absolute necessity of the human in the loop to catch hallucinations and bias.
Hmm. And those strict IPA safe harbor rules for de-identification, no dates except the year. And the ethical burden in publishing. Disclose AI use, but know that you are still 100% accountable for the final product.
We really are in the driver's seat here, aren't we? The sources suggest we shouldn't just sit back and predict what AI will do to clinical research. We should actively shape it. I like that quote, invoking Isaac Asimov.
Yeah, the idea of choosing the future we want. Choose a future, a good future, a useful future, and make the kind of prediction that will alter human emotions and reactions so that the future you predicted will be brought about.
It's about proactive, responsible adoption, not just letting the technology happen to us.
Precisely. And that means digging into those guidance documents, implementing those governance frameworks, starting now.
Well said. So, go forth, explore those documents we mentioned, and we'll see you on the next deep dive.